Hello, and welcome to the third lecture under Chapter 12, Airway Management. As always, this is Keith Woodmeyer with Wayne County EMS. We are going to review Airway Assessment. You must perform a primary survey on every patient, each and every one of them. Primary survey begins after the scene or situation has been found and made safe, and you have gained access to the patient. The purpose of the primary survey is to find and care for immediate life-threatening problems. As you approach the patient, you will first form a general impression of him or her to determine if he or she appears sick or not sick. This is a skill that you will hone in time. Sick, not sick. You probably have some degree of determining this now. You can walk in and see a your child, your spouse, your family member, and if you see them laying in bed, they look like they're barely conscious and coherent. Their skin is very, diaphoretic. They don't really look like they're paying much attention. Obviously, they're sick. You will also determine the urgency or further assessment and care. Using your senses of sight and hearing, look and listen, quickly determine the patient is ill, a medical patient, or injured, a trauma patient. Look at the patient and determine if he or she has any life-threatening problems. If life-threatening condition is found, you must treat it immediately. Don't stop, don't pass go, don't collect $200, just go directly to treating your patient's immediate life threat. After forming a general impression of the patient, you must assess the patient's level of responsiveness. Begin by speaking to your patient. If the patient appears to be awake, tell the patient your first name and identify yourself as an EMT. Explain that you are here to help. You may ask, why did you call 911 today? If the patient appears to be asleep, gently rub their shoulder and ask, are you okay? Or, can you hear me? Do not move the patient. When we are judging level of consciousness, there's an acronym that you should utilize. It's called AVPU, and that's A-V-P-U. And what we're assessing there is whether they are alert, they are responsive to verbal stimuli, which means that when I shout, hello, Mr. Smith, they respond back, or they make some kind of sound. Responsive to painful stimuli would be if I rub their sternum or if I rub their shoulder and they move or they twitch or they moan, then that would be responsive to painful stimuli. And then unresponsive is if they're not responsive to anything. Signs of an adequate airway. Just look at yourself breathing now. If your airway is open, you can hear and feel air moving in and out. If the patient's talking clearly and speaking in full sentences or crying without difficulty, that generally implies that the airway is adequate. The sound of the voice is normal for the patient. You don't hear any high-pitched sounds or anything distorting it. Signs of inadequate airway. Obviously, not every sign listed below is present in every patient who has an inadequate airway. Unusual sounds are heard with breathing, such as stridor, which is a high-pitched, harsh sound, usually associated with an upper airway obstruction, or snoring, which is like a gurgly sound, again also usually associated with upper airway obstruction. Awake patient is unable to speak or voice sounds hoarse. There's no air movement. airway obstruction due to the tongue, food, vomit, blood, teeth, or foreign body, or swelling due to trauma or infection. A patient who is alert and talking clearly or crying without difficulty has an open or patent airway. If the patient is unable to speak, cry, cough, or make any other sounds, his airway is completely obstructed. If the patient has noisy breathing, such as snoring, gurgling, he has a partial airway obstruction. One of the most important actions that you can perform is opening the airway of an unresponsive patient. An unresponsive patient loses the ability to keep his or her airway open because he's lost muscle tone. This causes the soft tissue of the throat and base of the tongue to relax. The tongue falls back into the throat, blocking the airway. Because the tongue is attached to the lower jaw, moving the jaw forward will lift the tongue away from the back of the throat. The crossed finger technique pictured here may be used to open the mouth of an unresponsive patient. To perform this technique, kneel above and behind the patient. Cross the thumb and forefinger of one gloved hand. Place the thumb of the patient's on the patient's lower front teeth and your forefinger on the upper front teeth, and use a scissor motion and a finger snapping motion to open the mouth. Personally, I will say this, and most of your instructors here will say the same thing, I will never ever stick my fingers in a patient's mouth. This is because patients' reflexes and the strength of the jaw, they could have the ability to bite your fingers to cause a complete amputation of your fingers. The head tilt chin lift, this is the most common method. The head tilt chin lift is the most effective method of opening the airway in a patient with no known or suspected trauma to the head or neck. It requires no equipment and is simple to perform. When done correctly, the base of the tongue will be displaced from blocking the back of the throat. To perform a head tilt chin lift, position the patient on his back. Place your hand closest to the patient's head on his forehead. Apply back pressure with your palm, gently tilting the patient's head backward. Place the fingers of your hand that is closest to the patient's feet under the bony part of his chin. Do not compress the soft tissue under the chin. Doing so can result in an airway obstruction. Lift the chin forward and support the jaw. Make sure the patient's mouth is open. If the patient is wearing dentures and they fit well, leave them in place. If the dentures are loose or do not fit well, remove them. And look, listen, and feel for breathing. Use the jaw thrust maneuver to open the airway of an unresponsive patient when trauma to the head or neck is suspected. Although this method of opening the airway is effective, it is less effective than the head tilt chin lift, and is more tiring because of this technique. Because this technique requires the use of both hands, a second rescuer will be needed if the patient requires ventilation. After opening the airway, look in the mouth of every unresponsive patient and any unresponsive patient who cannot protect her airway. This can be done by opening the patient's mouth with your gloved hand. Look inside the patient's mouth for an actual or a potential airway obstruction, such as a foreign body, blood, vomit, teeth, or the patient's tongue. If you see a foreign body in the patient's mouth, attempt to remove it. You can attempt with a gloved finger. I would more likely suggest to utilize some sort of suction catheter, like a hard catheter. If there's blood, vomitus, or other body fluids in the patient's airway, clear it with suctioning. That is the end of third lecture for Airway Management of Chapter 2.